So the topic this morning is the use of synthetic mid-urethral slings for the treatment of female stress incontinence. The bulk of this talk will focus on the TVT, which is the tension-free vaginal tape, the prototype of the tension-free mid-urethral sling. I'd like to look at some of the outcomes and as well as some of the complications associated with the use of the TVT. Before discussing the synthetic mid-urethral sling, I'd like to review some of the traditional surgical approaches to the treatment of stress incontinence. First of all, female incontinence is quite common. A recent survey done in Norway demonstrated that close to 40% of postmenopausal women suffer from some degree of stress incontinence. Because this is such a prevalent condition, it carries with it significant social and economic burdens. The cost estimated in the United States for treatment of stress incontinence is close to $30 billion on an annual basis. And because of this, everybody wants a piece of the rewards, be it financial or otherwise. And when we look at the treatment options, there's a huge array of treatment options that span from conservative to surgical. And when we look at some of the data supporting the use of medications, surgeries, and devices, we should keep in mind that there's a significant financial issue at the heart of perhaps some of the promotion of some of these techniques and medications.
Kevin, is it age-related? As you get older, the incidence increases?
Mm-hmm. Yeah, the risk factors would be age, parity, previous pelvic surgery. The female incontinence really presents a quality of life issue for the patient, and when we consider surgical treatment of this, we have to keep in mind that it really is a quality of life issue, does not represent a risk to the patient's life, and the ideal surgical procedure would carry with it a high cure rate, a low morbidity, and be resource efficient. The current surgical treatment options for female stress incontinence include the following procedures. The top two procedures here are the retropubic suspension and bladder neck slings, which are really the gold standard procedures to which all other minimally invasive procedures should be compared. More recently, the transvaginal needle suspensions have been developed. These are less invasive treatment approaches for female stress incontinence, and more recently the tension-free mid-urethral slings, which have been in use since the mid-90s. To start off with, the gold standard procedures are the Birch-Culpel suspension and the autologous bladder neck sling. These are procedures that have been in use for almost 30 years and have demonstrated good long-term outcomes with well-defined morbidity and complications. The Birch-Culpel suspension was originally described in '61 by a urogynecologist and involves suspending the paravaginal tissue to Cooper's ligament. This has proven to be an excellent procedure for the treatment of stress incontinence associated with urethral hypermobility, and the success rates have been durable beyond 10 years. The drawbacks to the Birch procedure, and the reason minimally invasive surgical approaches have become more popular, is that because the procedure itself involves an abdominal incision and a hospital stay of 2 to 3 days. The long-term complications include prolapse, de novo storage symptoms, and voiding dysfunction, specifically long-term retention, which is encountered in up to 5% of patients. As well, this approach may not be as effective in the patient with the immobile bladder neck, which is defined as an intrinsic sphincter deficiency.
So good results are 69%?
That was one paper.
Well, I mean, there are not many papers out with long-term results. I mean, I think we actually won yesterday at 81% at 10 years.
Yeah.
I mean, so that's good results then. So 69% for this operation, whatever is good, and that's the gold standard?
Well, the problem with incontinence literature is that it's never been well defined. The patients often in the papers that you see, the characteristics of the patients aren't often well described. A lot of patients are lost to follow-up over time, and outcomes.
Good long-term follow-ups in the birch.
The best data that we have would suggest that the birch is a durable operation and it's effective as compared to all other options. And again, the outcomes, how you define a success in incontinence, is also quite variable.
What do you mean by storage syndrome? Does that include the long-term retention of patients, or is that separate?
That would be a separate. Long-term retention would be separate. These are the irritative voiding symptoms. The autologous bladder neck sling is also a procedure that's been around for greater than 10 years. This is an excellent procedure for treatment of genuine stress incontinence associated with bladder neck hypermobility. And as well, this is really probably the best procedure for the treatment of these patients with the immobile bladder neck and intrinsic sphincter deficiency. This procedure itself involves harvesting a segment of fascia, either from the rectus fascia or from fascia lata, and suspending it underneath the bladder neck. And the real challenge, to my understanding, with this procedure is the judgment: how much tension is the sling put under at the bladder neck. The real drawback to this procedure is that it is technically challenging with respect to how much tension is put on the fascia at the bladder neck, because this can lead to long-term voiding dysfunction up to 10% of patients. And this is really one of the drawbacks to this procedure, is that it can lead to urinary retention in up to 10%. As well, there's morbidity associated with the harvesting of rectus fascia and fascia lata, and there have been reported cases of sling erosion, although it is quite rare. There have been a number of attempts to try and improve on these gold standard procedures. Attempts to change these procedures to make them less morbid, and really one of the approaches is the laparoscopic approach to the birch. This involves obviously laparoscopy. It can be done preperitoneally or transperitoneally. The challenge here is that it's a technically difficult procedure. It involves skills that may not be familiar to urologists or urogynecologists, and the long-term data have shown that this procedure is really not as effective as the open birch procedure. Looking at the bladder neck sling, all sorts of materials have been used to replace the autologous fascia, and this is all an attempt to make the procedure more time efficient and less morbid for the patient. Allograft materials have been used. Cadaveric fascia is one particular material that has been used. There have been concerns with the allograft material about transmission of prions, and although there hasn't been a documented case in the use of allograft material for female incontinence, it is a concern. Allograft material, however, has been used and is still used in some centers, but the evidence would suggest that the allograft material is not as strong as autologous rectus fascia, and that there is a significant early failure rate associated with the use of these allograft materials. Synthetics have also been used, and this is where synthetics developed a bad name. Various synthetics have been used, including Morrison and Gore-Tex. Morrison was found to be highly inflammatory, and the erosion rate with the use of Morrison was up to 10% to 15%, and this is no longer used. Gore-Tex has associated problems as well and is no longer used. It's a very fine weave material, and it's felt that the diameter of the weave allowed access of bacteria into the graft but did not allow access of macrophages, and this procedure has been abandoned due to the high rate of infections.
Kevin, did you come across any histological studies as to what the peak of a fascial sling is?
I've got some slides on some histologic data on the Morrison sling and the Proline slings, but I don't have anything on what happens to rectus fascia.
Does it require require a blood supply? Does it calcify? Is it a graft or is it a dead piece of skin?
My understanding is it leads to a scarring in that area. I don't think it. I don't really know actually, but I don't think it requires a blood supply. What? You haven't seen any redos on those.
It's an ingrowth of collagen.
How long after surgery, after the visit, were you guys doing it? Weeks, months, years?
Howard, do you have any experience with operating on these?
Oh, we've taken them out. Usually it's just, it's not calcified, it's just fibrotic.
I'm talking about rectus fascia.
Yeah.
Is the fascia still there?
Well, there's this fibrotic mass of tissue, and when occasionally send it off to the pathologist, I've never seen a report of calcification. It's just basically fibrotic tissue. They can't recognize that.
I've done some on that Marnix erosion,
Mm-hmm.
and then gone back after they've been repaired and gone back to an autologous fascia. It's not that the calcification is very scarred, it's a
Mm-hmm.
vascular scar. I've never go in after a rectus fascia.
And I've had several rectus slings fail, and I wondered, did it disappear too soon, or did it scar, fix open?
Fails probably because it gets loose.
This is for type 3 neurogenic incontinence.
I'm having a comment because I've been using now slings for both type 2 and type 3. But I think if you do a birch, sometimes you miss the ISD patient, unless you could urodynamisol, and even then you can miss it. So I think that's one of the reasons that birches fail. So I think with slings, that's probably a better way to treat them.
Would you agree, though, it's more technically challenging with respect to how much tension you put on the bladder neck and the risk of...
Low tension with bladder neck sling. Low tension.
How does it cure the ISD then?
But what you do is that you elevate the bladder neck by putting your vaginal tight, and then you tie your sling across your rectus fascia. It should always be tension free, otherwise it be tight. When that vaginal tight comes out, it's tight. You also always gauge it, for the system before you tie it down. But I found that early on, there were mid-urethral very, very proximal.
The bladder neck, yeah. Transvaginal needle suspensions have also been around for over 30 years. These were developed in an attempt to decrease the morbidity associated with anti-incontinence procedures. Essentially, what this involves is the passage of needles from the vaginal vault up over the rectus muscles, and various sutures have been used. Various methods for pledgeting these sutures over the rectus have been used. The drawbacks to this procedure really is that over the long term, the outcomes have not been as durable. The short-term outcomes have been very good, but the long-term outcomes have really decayed.
I can tell you because we looked at ours, we've done lots of these, already leading practice 11. We had 88% 5-year, 30% 10-year. So we followed patients. That's why I've asked. We were the first published group that followed patients up to 10 years, and we showed it was 33% in the ones that we looked at.
Mm-hmm.
So that's the number that I tell all patients. And that's why it's so interesting is that we could find many other published anti-incontinence procedures that published 10-year results. It's all 2 years, 1 year of post-op follow-up. And so ours is, I can tell you right now, it's 33% for this procedure.
It's probably down to 20 by 15 now.
Yeah.
You stopped doing it, didn't you?
Stopped doing it. I do occasional and very select patients. But the bell went on when that came out.
It was kind of a sexy procedure in the mid to late 80s. You do it as an outpatient.
But nobody published 10 years until we published 10 years, and then all of a sudden everybody said, holy cow.
Yeah. So we've talked about the Birch cupel suspension, the autologous bladder neck sling, and as well I've talked about the synthetic bladder neck slings Now I'd like to talk about the synthetic mid-urethral sling, which has been around since the mid-90s, and it was first described in a paper in 1996 by a Swedish urogynecologist named Olmston. In 96, he reported on 75 patients with stress incontinence that he treated with a modified, what he called a modified intravaginal slingplasty, involving a proline mesh, which was passed from the vaginal vault underneath the urethra in patients under local anesthetic. The 2-year follow-up on these patients demonstrated a 84% cure, and he defined cure as a negative stress test, which he did in his office. The concept of the mid-urethral continence is really a theory that the same professor put forth in conjunction with another urogynecologist in the United States, John Delancey, and this is the integral theory. In the past, the continence was felt to be related to the position of the bladder neck, and this is the so-called pressure transmission theory. And it was felt that as the bladder neck descends outside of the abdominal cavity, stress is distributed unevenly over the bladder and the urethra, and as a result there was pressure on the bladder, and this results in the leakage of urine. Problems with this theory is that some women who do show bladder neck descent are completely continent, and some of the transvaginal needle suspensions result in continence without actually elevating the bladder neck. And this is where the integral theory may help us explain why these patients are continent. The integral theory involves the emphasis on the ligaments and the suburethral connective tissue located under the mid-urethra, which supports the urethra. And this integral theory, which was described by Olmston, involves a hammock of tissue traversing underneath the urethra in the mid-urethral area, connected up to the arcus tendineus. And here's another picture of what's going on here. This essentially, the arcus tendineus runs from the pubic symphysis to the ischial spine. From this, medially is the endopelvic fascia, the anterior vaginal wall, which passes underneath the urethra. And in conjunction with this, the pubococcygeus muscles pass around the outlets of the pelvic viscera and support this hammock of tissue. During stress maneuvers, on the bottom right here, you can see a case where the ligaments in the hammock are weak, and during a stress maneuver, the bladder neck descends and opens up, and urine is expelled. Whereas if these ligaments and fascial supports are intact, there is a closing of the mid-urethral segment during stress maneuvers. So, based on these findings, the observations were based on experiments that he carried out on cadavers and as well on MRI exams of the pelvis. Based on this, the mid-urethral tape was developed, and this involves placing a proline tape under the mid-urethra under tension-free conditions at rest, and during stress maneuvers it's felt that this replaces the weakened suburethral hammock, and during stress the urethra kinks off in this position and prevents the loss of urine. Prior to the reporting of this mid-urethral synthetic sling in 96, the urogynecologists in Sweden had been involved in using this very same approach with different synthetic materials, including Morrison and Gore-Tex, and they ran into the same problems that were experienced with the Morrison and Gore-Tex bladder neck slings. There was a high erosion rate, high infection rate, and therefore these synthetics were abandoned. The polypropylene mesh, which is the mesh used in the TVT, is felt to be different, and there's been some in vivo data which supports this. This is some data from a human study where they biopsied women undergoing placement of the TVT prior to the tape placement, and as well they biopsied women who had a Morrison mesh in the bladder neck region, and they found that there was a significant inflammatory response at the bladder neck in the tissues with the Morrison mesh. Whereas when they looked at the proline mesh, there was really no inflammatory response, and the tissue seemed to tolerate the proline well. So this is the logic behind the placement of the tape in the mid-urethra versus the bladder neck, and these experiments supported the use of proline mesh versus the previous meshes, which had been found to be not well tolerated by the tissue.
The integral theory, of course, is very controversial. Do you think, after reading the literature, do you think it makes any sense?
I like this picture right here. That seems to make sense to me.
No, but that explains why the tape works. It doesn't explain. It doesn't prove that the integral theory is.
Yeah.
See, I think the integral theory is extremely simplistic, like all the other theories that we have. There's another theory that you didn't discuss, which involves the levator anine, and it's been shown in a number of experiments that plays a role as well. You know, the striated muscle plays a role, and that contracts and changes position.
Yeah.
And I think all the theories together have to be integrated, and that's the integral theory. All
Yeah.
the theories, not just one theory.
Exactly.
It works. I mean, we're not going to argue about that, but it's probably not working because of the reasons that this guy said.
Yeah. Well, I agree. I think it's called the integral theory because it integrates the levators, the pubococcygeus, the ligaments, the anterior vaginal wall. It integrates all these components of the floor of the pelvis and uses them to explain incontinence.
But he also negates the effect of the bladder neck and the position of the bladder neck in the retropubic space. And there's a lot of evidence that plays a role.
Yeah. Talking about the mesh material, the polypropylene mesh has also been studied with biomechanical investigations, and right at the beginning of my talk, I talked about the fact that incontinence is a big business, and people are always trying to sell you things. And this gets back to the TVT, which is a trademark of a specific company, and they've patented the proline mesh. So one proline mesh is not the same as the next proline mesh. And this is an article where they studied the TVT mesh and compared it to the Spark mesh, which is from a different company. And they're both polypropylene meshes, but because of the pore size and the weave, there are biomechanical differences between these two meshes. Most of the data, the long-term data, has to do with the use of this TVT mesh. So the TVT procedure involves the passage of a proline mesh with the use of these 6 millimeter sharp trocars, and placement of this mesh underneath the mid-urethral area up to the skin and the anterior abdominal wall. When the procedure was originally described in '96, it was in a patient population that was quite selected. We'll talk about that a bit later. But these patients were treated under local anesthetic. It involved passage of the needles, like I said, from the vaginal vault up to the anterior vaginal wall. In the initial description, there was also a catheter guide which was used to tent the bladder posteriorly in an effort to bring it away from the space of Retzius. That, however, is no longer used. Once the trocars are passed underneath the symphysis up to the anterior abdominal wall, the tape is pulled through, and the plastic sheath which covers the proline mesh is removed after the tape has been positioned. The initial description of this procedure was the patients were treated with IV sedation and local anesthetic, and therefore they were able to carry out a cough stress test, and the tension of the tape was adjusted such that with their bladder filled to 300 cc's, there was only a few drops of urine leakage with the stress test. The plastic sheath, once the plastic sheath is removed from the tape, the characteristics of the mesh allow it to bind to the surrounding fat and connective tissue, and therefore it's very fixed in position almost immediately. The tape is then cut at the skin surface. There's no tensioning sutures at all, and the skin is closed. Small vaginal incision is closed up. I'd like to look at two papers, really. There's now 7-year data on the first 90 patients which were treated with the TVT. This comes from the Swedish group. This is a sort of a case series, really looking at the first 90 patients that were treated in 3 centers in Sweden and Finland. These patients were treated in 95, 96. They were again selected patients. All these patients underwent preoperative urodynamics and pad tests, as well as having filled out quality of life questionnaires. Patients with significant prolapse, detrusor instability demonstrated on urodynamics, and intrinsic sphincter deficiency were excluded. The postmenopausal patients were all placed on estrogen, topical estrogens, for a 3-month period prior to the procedure. The cure was defined as a negative stress test, which again involved filling the bladder to 300 cc's and having the patient cough, as well as a negative 24-hour pad test, and an improvement in the quality of life of greater than 90%. After 7 years, this data was published in December 2004. 80 out of the 90 patients were still available for assessment. 3 were deceased and 6 were living in nursing homes and were not able to respond to come in.
What was the average age of the patient?
60.
94.
Yeah.
Marty, that's the average age of the patient here.
Yeah.
I don't think anybody died from incontinence. I don't know what they died from. But, yeah. Yeah. When they assessed the data, they excluded these 10 patients, so it's not an intention to treat analysis. They really just looked at the outcomes of the patients that they could assess. And what they found was that 81% of these patients met the criteria for a cure. And when they looked at the complications, really there were no erosions or any voiding dysfunction reported. They reported on the incidence of prolapse, de novo urgency, and recurrent urinary tract infections. One of the strengths of the TVT procedure is that the data is reproducible. It has been this short-term and intermediate-term success has been reproduced in other centers around the world, and most people would agree that it is an effective procedure and that there are good data to support that it's effective up to 4 years and up to 7 years in selected patients in the hands of the Swedish urogynecologists. The advantages of the procedure really are that these patients are treated as outpatients. They go home without a catheter. They don't require general anesthetic, and the rate of voiding dysfunction may be lower due to the fact that it's a tension-free tape when compared to the bladder neck sling. When looking at the use of TVT for the treatment of intrinsic sphincter deficiency, there have been a couple studies looking at this. ISD is defined variously based on Valsalva leak point pressures or based on urethral pressure profiles. In this series from the Swedish group, again, they defined it based on a mean urethral closing pressure of less than 20. They looked at 49 patients, and they found that overall the cure rate was not too bad at 74% over 4 years. However, in those patients who had a fixed bladder neck, there was really not a very good cure in this subpopulation. Another study looked at the patients with ISD or type 3 incontinence and found again that there was a higher failure rate in those with a open bladder neck. The last study I wanted to look at is a randomized controlled trial prospectively comparing TVT to the Birch Copal suspension. This is a study that was organized in the United Kingdom, involved urologists and gynecologists in Great Britain and Ireland. The 6-month results for this were published in 2002, and there's now 2-year follow-up data from this trial. The goal of this study was to look at patients with genuine stress incontinence, again, highly selected patients, and compare the effectiveness of TVT compared with the Birch. The inclusion criteria: women with stress incontinence who completed their family. Again, all patients underwent a pad test, urodynamics, and quality of life questionnaires. These patients were selected, and those with documented detrusor overactivity on urodynamics were excluded, as were those with significant vault prolapse requiring surgery. Those with previous surgery were excluded, and those with a voiding dysfunction, meaning high post-void residual or an obstructed picture on urodynamics, were also excluded. The TVT was carried out as described by Olmsted. All surgeons in the trial underwent training, and the Birch was carried out according to the standard techniques. The outcome measures were very similar to the previous prospective series. They looked at the quality of life as well as looked at the presence or absence of a positive stress test. The primary outcome was the cure of stress incontinence as defined by urodynamics and a 1-hour pad test. There was a number of secondary outcomes which included quality of life, and these were measured as outlined here. Their initial power calculation, they required over 400 patients. However, they were unable to attain this level of patient recruitment, and they eventually recruited 340 patients, which they randomized. One of the significant features of this trial is that after randomization, more patients in the Birch group withdrew from the procedure, and this is something that may, in the end, favor the results with respect to TVT, because it's presumed. It was actually documented that these patients who withdrew had less severe stress incontinence. So in their intention to treat analysis, where they assumed that all people who withdrew were failures, they in fact favor the TVT group, because these patients likely would have been cured. Their baseline characteristics were quite similar, and when you looked at the results, first of all, the majority of patients undergoing the Birch required a general anesthetic, where only 2% undergoing the TVT required a general anesthetic. Intraoperatively, there was more complications in the TVT group, 10% versus 2%. And when we looked postoperatively, the hospital stay was significantly longer in the Birch group. And as well, the time to return to work was significantly greater in those patients undergoing the Birch. And what they concluded basically is a summary of what I've just talked about here, is that there was more intraoperative complications with the TVT, but when you look at the blood loss and the postoperative complications, these were greater in the Birch group. When we looked at cure at 6 months, the cure was virtually the same between the two groups based on urodynamics. And again, looking at pad tests, the cure between the two groups was very similar. And this is an intention to treat analysis, so we've assumed that all people that dropped out of the Birch group are failures. When the quality of life was examined, TVT patients had a significantly better quality of life based on a number of parameters, including emotional, social function, and otherwise. Their conclusions were that the TVT was equivalent to the Birch at 6 months. The OR complications with the TVT were greater than the Birch. However, the post-op recovery and post-op complications were greater in the Birch group. So this was all interesting, but really 6 months data doesn't tell us much. And this has been followed up recently in 2004 with 2-year data from the same trial. Again, patients were followed up, assessed with stress test and a pad test. Cure was defined as a negative stress test, and quality of life measures were also assessed. Looking at any trial, it's important to look at who is still in the trial, what's happened to the patients that are no longer there, and there were significant loss to follow-up in both groups, and this is something that they took into account when they analyzed the data, and they took a number of assumptions. They assumed that, and they made a number of assumptions. One of the assumptions was that all people that were lost were failures. Then they assumed that all people who were lost were cures. And then they also carried out a last observed result carried forward analysis. And what they found was that the cure between the two treatment groups was very similar. And again, quality of life showed a difference favoring the TVT group at 2 years. When you look at the complications associated with the two procedures, the Birch does a better job at curing cystocele. However, there is an increased risk of enterocele and rectocele in the Birch group, and this was significant as 5 patients underwent prolapse repair in the Birch versus none in the TVT group. And this is basically more of the complications as described, and as well the incidence of long-term voiding dysfunction was higher in the Birch group compared to the TVT. So they concluded that the TVT appeared as effective as the Birch for the treatment of stress incontinence over 2 years. So that's really the best data we have. It's short-term, and it'll remain to be seen whether these patients can be followed up over longer term to determine how effective these two strategies are in comparison. I'd like to talk about the complications of TVT.
I don't think you can run that without making a couple of statements. One is, what is really intriguing is that none of us would accept 6 months and 2-year data for anything else. It's amazing. The second thing is that when you highly select patients and exclude, which all of these studies do, and then put it in the hands of highly trained and interested surgeons, you really skewer the results of any procedure that you can put out in the population. And the third thing is, pediatric guys will understand it. It sounds like
not in this room.
It sounds like you're listening to a lecture that Creevy and Company gave years ago. There's 97 operations for hypospadias. All it really tells you is that we still don't understand, and we still don't have a really good operation. And comparing stuff when you're talking about 6 months and putting in emotional and discomfort factors, comparing the Birches against the TVT, you don't need to do that as a study. You know what the answer is. The Birch is going to have more discomfort. And we just don't have a good operation.
Yeah.
And we're looking at stuff very early on. And all of the long-term complications, which you're going to talk to about now, erosions and things, aren't going to occur in the first 2 years unless somebody's really stupid. They got to be 5 to 10 years. What amazes me is that nobody in the incontinence literature sits down with 5 and 10 year results like every other operation that we do.
Yeah. I disagree. I mean, I certainly take the task of the data, but I disagree with the recent operation, which is good, which has 15-year data, called the pubovaginal sling, and no one bothers to compare any of these novel operations against the sling because they know they would lose. I mean, and it's straightforward. The data on 15 years from that McGuire and Blavis have both published in their own hands show excellent cure rates. If you were cured 1 year out from a sling, you are cured 15 years out from a sling, no new complications.
Yeah, but that's data from 2 excellent surgeons. An operation is only good if everybody can do it.
Anyone can do a sling. It's not a hard operation.
It's not a hard operation, but the results are not as good as you make them out to be. I think there's another very important point that you've missed. In this article, the Karen Ward article has been very highly quoted in the literature, even though it's only gone up 2 years. If you really want to read the article carefully, that's fine, but read the editorial that William Steers wrote in another article on this operation. It's one of the best editorials I've ever seen. I think all the residents should have a look at it, and I'll provide it to you. And he highly criticizes this paper, criticizes the tape. He really goes after it. And according to his interpretation of the paper, the long-term survival, or long-term results are probably not going to be anywhere close to the suprapubic repair. There's a tremendous amount of controversy out there. You have to be very careful how you read the literature.
Yeah.
Because, I look at my own results, and my Birches I did 7 years ago are failing. The slings they're doing much better for several years out now. The slings seem to be doing better. I'm not sure why. The Birches good operation. There are some that fail. And it's a big operation.
Yeah.
No, speaking of editorials, there's another editorial again by Ed McGuire, which I think in the Journal of Urology, which was the best thing. Is that because it's new doesn't mean it's good. And it really got into sling. And that's the first editorial or article that told me 5 and 10 years results in any of these operations. Maybe Christine can give us some more, but it stuns me when you listen that it's 2 months, 6 months. I mean, we'd be shot in oncology if we started this kind of stuff. But the Ed McGuire, and it's 3 years ago in Journal of Urology, it just tells you everything. I think it's did you read that too?
Yeah.
That's a phenomenal metaphor.
Yeah. Anyway, I think you guys are going to like this part, though. We're talking about the complications now. This will be fun. So to finish the pro TVT portion of the talk, complications. This is the complications that were. I looked at a number of articles. This was the article that had the most number of procedures. There was close to 1,500 procedures. This comes from Finland, and it includes both academic and non-academic centers. In Finland, they don't let anyone do a TVT unless they get trained, and they do 10 procedures before they do one by themselves. So this may represent lower incidence of complications compared with those who maybe just do it based on the instructions in the package. But the intra-op complications, bladder perforation, 4%, major vessel injury, which is potentially devastating complication, was reported in one case. The early postoperative complications are as listed. Urinary retention close to 8%. Nerve injuries include injury to the obturator nerve in one case, which resolved after 2 weeks. The late post-op complications are the ones that we're really concerned about, and these are the things that are starting to show up in the literature. And the main ones that I think we may be seeing more of over the next 5 to 10 years are erosions. This includes erosions through the urethra, erosions through the vaginal wall, and erosions into the bladder. In this series of 1,500 TVTs, they only reported 3 erosions. 1 was into the urethra and 2 were into the bladder. The other concern is urethral obstruction. This is a complication that occurs early on in about 8% of patients, but beyond 6 weeks it occurs in about 3% of patients. Bladder perforation is something that happens intraoperatively, and clinically this may not be that significant. All patients undergo cystoscopy, and you can usually identify the needles going through the bladder neck, and the needles can simply be removed and placed again. And some people would advocate leaving a catheter for a few days. However, most people don't. Urethral erosion is probably one of the more devastating complications, at least when you do the cystoscopy and you see this appearance in the mid-urethra. When I reviewed the literature, there was 13 cases reported of urethral erosion, but this may represent just the beginning of this complication, or it may represent something that's been going on for a while. But there are more case reports over the last 3 years with respect to urethral erosion. These patients tend to present with irritative and obstructive symptoms, recurrent urinary tract infections, and pain. The majority of these patients, when you look at the case reports, had postoperative retention, and this may hint at the reason why these tapes are eroding due to the fact that they may have been placed under too much tension initially. Looking at the repair, how do people repair these erosions? There were a number of different approaches. The most common approach was simply carrying out a transvaginal excision of the tape with primary closure of the urethra. And interestingly enough, most of these case reports report that the patients were continent following this without putting in any kind of pubovaginal sling or any other secondary anti-incontinence procedure. There was a case report of an endoscopic repair, and this was carried out using endoscopic scissors. The portion of the tape was excised, and the patient was doing well after 10 months post-repair. Bladder erosion, I found 9 case reports of bladder erosion. Again, these patients present with similar type picture, recurrent urinary tract infections, pain, irritative symptoms, and the majority of these can be removed endoscopically. There have been various methods described to remove these portions of tape using scissors, laser, and in one case they actually filled the bladder up and put a laparoscopic trocar into the bladder to grasp the tape to facilitate resecting this tape endoscopically. So the bottom line from the literature is that you don't need to excise the whole tape. You can just excise the portion that's in the bladder or in the urethra, and that most of the authors report that these patients are continent following excision of either the intravesical portion of the tape or the intraurethral portion. Now I know vaginal erosion has also been reported. It's actually probably the most common type of erosion. Most people would simply treat this with excision and primary closure of the vaginal mucosa. These patients can present with a number of different clinical scenarios, including a dyspareunia and vaginal discharge. And the most commonly reported approach to treating this is to simply excise the tape and close the anterior vaginal wall. And most authors seem to use estrogen to help with the healing.
What was the instance of vaginal erosions in your review? Most
of the erosions are not reported as complications. They're the rare complications. So in most series, it would be under a percent, under 0.5%. But because as Dr. Wright pointed out, a lot of these studies, a lot of these case series are only 2-year follow-up, 4-year follow-up. We may not be seeing these erosions till later, and so we may not be capturing them in the literature yet.
In the absence of erosions, do you find any information on that?
There's a couple papers on sexual function following the TVT, but I didn't read them.
Is that Hummican again?
I don't know.
How far out were they mostly erosions before you?
I think it was pretty early. It was pretty early. The difference between the Marlix, the Gore-Tex, the bladder neck slings, to my understanding, are for the treatment of ISD were placed under some tension at the bladder neck. So the tension in combination with the inflammatory nature around these synthetics led to the erosion. And people are stating that because this is a more tolerated mesh, this proline mesh, it's better tolerated and it's not placed under tension, the risk of erosion theoretically would be lower.
When the tape came out, Dr. Wilkie and I did some cases together. We had the tape that was provided to us, and the operation is very simple.
How about removal?
Removal. That's a whole new story. I was going to make a comment after you finished.
Why don't I just whip through the rest? Urethral obstruction I won't really talk about because I don't know how many people are doing the TVT here. Nobody. Anyone?
Why? Why are we doing this?
I don't know. Anyway, I won't talk about obstruction because that's really a management issue and maybe not of so much interest. Rare complications including, aside from erosion, are injury to the bowel, potentially devastating, major vessel injury, and there was a case report of necrotizing fasciitis. And just when you think we're starting to get some good data on the TVT, the French have now come out with the TOT, and so we're supposed to jump on the bandwagon there. And the gimmick here is that because the tape is passed through the obturator foramen, there will be a lower risk of perforation of the bladder, the bowel, and blood vessels. There has been one randomized trial with 1-year follow-up showing that it's equivalent to the TVT with a lower rate of bladder perforation and equivalent cure. Here's a few pictures of what's going on. The operative time for this in this paper was 14 minutes. And again, patients were discharged the same day without a catheter. And this is something I heard when I was in the OR, I think you may recognize and basically, I just wanted to sort of wrap it up with a survey that was carried out in 2002, asking members of the International Urogynecology Association what they were doing. So let's find out what people are doing. And obviously, this is a select population of physicians. These are people who are probably reading the journal routinely. Maybe they're more susceptible to trying new things. But maybe they work for the company. I don't know. Anyway, so the TVT was actually the most commonly used procedure for primary treatment of incontinence, followed closely by the Birch. In those patients with failed primary procedures and those with intrinsic sphincter deficiency, TVT again was the most commonly used procedure. So in conclusion, the short-term data appears to support the use of TVT. It seems to be as safe and effective at least in the short term. There is a associated decreased short-term morbidity, but I think in order to get involved in doing this, the patients have to be aware that there are specific complications associated with the use of synthetic slings, and these would be the risk of erosion. And when it comes right down to it, I think it may be an emotional decision for a lot of patients and physicians as to whether they want to use a synthetic material for treating a lifestyle issue, because these synthetics will be around for a long time, and we don't really know what's going to happen beyond 7 years.